Hello, everyone. My name is Hannah, and I am a research assistant working with ShiftTB. Today, I have the pleasure of interviewing Mr. Brian Citro on one of his recent tuberculosis papers about directly observed therapy, or DOT, which uses a human rights-based analysis. So, Brian, if you could go ahead and introduce yourself.
Sure. Thanks so much, Hannah, and thanks to Shift to TB for inviting me to speak with you today. So I'm a human rights lawyer and an independent researcher, and I live in Chicago. I've been working at the intersection of health and human rights and law since I graduated law school in 2010. I lived in India and worked for the UN Special Rapporteur on the Right to Health at the Lawyers Collective, Mr. Anand Grover. And since then, I've taught at law schools here in the US as a law professor, and I'm now working independently, working with the Stop TB Partnership, UNDP, WHO, and others on a variety of issues, but TB has been a big focus for about the past decade.
All right. Without further ado, we're going to begin this interview with the first
Thank you.
question.
Yep.
So your paper on tuberculosis and DOT using a human rights-based analysis was really intriguing to read. What would you say that the main arguments or the critical points that you really want your reader to take away from your paper are?
Yeah. Thank you. There's a lot of them actually in there. I think the overall uh, thing to take away is that the dogma of DOT, the dominance of DOT as the treatment model for TB is not supported by existing evidence. And in fact, there's a growing body of evidence that shows that DOT is quite harmful. And also that if you use the human rights lens, or if we're interested in promoting a rights-based response, that DOT really doesn't fit, it doesn't align with human rights, and it shouldn't be part of a rights-based response.
Mm. And that actually connects to the next question that I was going to
Yeah.
ask, is what do you think makes concepts and practices like DOT stay in use, stay in the recommendations, despite this evidence that it's not better and that there's evidence that shows that it's actually very harmful?
Yeah, I mean, I think that's the million or maybe billion-dollar question. I was thinking about that before we started here, and you know, I think the answer to that really at the highest level or the ground level, however you want to put whichever metaphor you'd like to choose, is around status quo bias and inertia, kind of broadly speaking. But then I think there is a large reason that's associated with the distrust of people affected by TB, and the fact that most people affected by TB have historically and still are, disadvantaged and marginalized in different ways, and often not in ways where they're mobilized as members of a group, which is different than, for instance, HIV, where you had disadvantaged and stigmatized groups, but that had more group identities that were able to mobilize in different ways. And so that comparison is in the paper actually, where to me, it's an elephant in the room, which is to say, if we were to, tomorrow say, you know what, DOT's working great for TB, let's do it for HIV. It would never pass. No one would accept that, and primarily people living with HIV wouldn't accept it. The criticism against using DOT for HIV was that it's a one-size-fits-all solution for a problem that is very different for each person depending on their life. And so, but here we are in TB still with DOT all these years later. The long and short of it, I do think there's a strong sense of inertia. There's a status quo bias there, but there is a real problematic mistrust or distrust of people with TB. That is, I think, also part of that kind of inertia. But at the highest level, I think that's largely why we're still using DOT, despite the growing evidence that it's harmful, and despite the lack of evidence from randomized controlled trials or observational studies, that the lack of evidence that it's more effective than self-administered treatment. We don't have that evidence, yet we're
So my
still.
next question is, coming from a background in law, how do you approach human rights within this TB field, having that law background and the social science background?
Yeah, so I think this paper is kind of an interesting example of that. And the dismantling the dogma of DOT is the paper we're talking about today, in the Northwestern Journal of Human Rights. It it uses human rights. It's more, it's less of a legal paper, as more on the social science side of things, where the human rights component is essentially taking five specific human rights, rather four specific human rights, and then the idea of dignity, or the ideas of dignity and autonomy, which are not necessarily rights themselves, but are the foundational principles on which the whole human rights regime has been built. So it's taking those specific rights and those principles, looking at their actual content, which you could say is their legal content. So, for example, the right to health, it means a lot of very specific things. One of them is that health services need to be accessible, acceptable, available, and of good quality. So we took kind of the legal content of the rights, and we looked at DOT and the impact that DOT has on people to see whether it conforms with those rights, or does it infringe upon those rights. And so that analysis, we did that for each of the rights, and then each of the principles. And we basically, it's pretty easy to see that in many cases, DOT threatens to infringe on those rights, or just it does violate those rights. And so that's the way we use human rights in this paper. But there's a lot of social science, the social science component is there as well. The thing that I really enjoyed doing, and I hope readers will enjoy as well, is the historical analysis. So there's a few other papers that also look at the history, but not in the same way we do. And it was really a lot of fun, honestly, going back and reading all the WHO documents that are online, and credit to them to putting them online, of how DOT basically came to be. Through early studies in India, the Madras study by Wallace Fox, and also Karel Stiblo, who did early studies in Tanzania. There's a few like foundational TB studies that eventually led to DOT. But what we show actually is that those studies in particular, and others as well, they didn't use DOT for the most part. And that there were lots of other things that were happening in those studies that, in our view, my co-authors and I, were the reasons that they were able to achieve certain things, whether it's treatment success rates, or in the case of the Madras study, it was the study that really took TB out of the sanatorium age and said, hey, people can be treated in their communities. And so, but we looked at that history, and then we looked at the history of how those studies and others kind of were taken by WHO and marketed strongly along with the DOTS, the DOTS strategy, and how that kind of led to what we have now, which is the global dominance of DOT as a treatment model, despite, as we said multiple times, that the evidence doesn't support it over self-administered treatment, and that there's a growing body of evidence that is quite harmful. As I said, we look at human dignity and autonomy. We
Mhm.
look at the right to health, and it is actually five rights, and then those principles. The right to participation, the right to be free from discrimination, the right to privacy, and then the right to science. Each of those rights is implicated by different aspects of DOT. Very quickly, the right to science basically requires that governments, the state, works to make sure that scientific progress is happening and that it's accessible to people, right? And so one of the arguments we make is that DOT has basically levied an enormous opportunity cost. What's the opportunity cost is that because DOT has been so dominant, uh, it's basically operated to the exclusion of any real research or efforts to come up with a better model. So we've had DOT going along, and no efforts and no funding, no support for considering better approaches to in terms of the treatment model. So that, in our view, infringes on the right to science. But the one that, and that's maybe something that's less, easily kind of graspable by folks,
Yeah.
but the one that might answer your question would be the right to privacy and confidentiality. And this is really about facility-based DOT, but it's also now about VDOT, or video DOT. So the idea is that, and I think anyone who works in TB knows this, that when people are forced to go to the clinic every day or multiple times a week, the chance that they're revealed as having TB, or as at least thinking they have TB, is really high. If you've been around the world and folks that work in clinics, you'll see most of them say DOT center, or tuberculosis center, which helps for people to find them, but it is not good for protecting people's privacy. So there's a lot of research that is not from a human rights perspective, but that looks at privacy and confidentiality, and clearly shows that confidentiality and privacy is breached. when folks are forced to do facility-based dot. And in our view, then, as a human rights lawyer, in my view, that is a rights violation, and dot is directly responsible for that.
Okay, thank you. So the next question is, what do you think that social scientists in this field should do or do differently to support person-centered care tuberculosis response? Like, what is your advice to other social scientists in the field?
Yeah, thank you. And so, by the way, I should say before we go too much longer that I was the lead author, but that I want to mention who my co-authors are. So it was also Dr. Jennifer Furin, Ria Lobo, Ingrid Schumann, and Timur Abdullayev. And so those three of those folks are TB survivors. So it was one thing that I'm proud of also and grateful to be a part of is a paper that's written by a diverse group of people from all over the world, gender and racial diversity, and that it's three out of the five are TB survivors. So they brought a very unique perspective, and Dr. Fern is a TB doctor who works globally as well. So the paper makes two suggestions or recommendations for how to move forward. One is differentiated people-centered care, which is the term in the standard used for HIV, and which we think is how we should approach TB treatment for people. But the other part of it is and to empower communities. So the principle, the way we frame it is community empowerment for a participatory response. What does that mean? What it means is that if we want to change DOT, if we want to remove or eliminate DOT, the models that we need to develop or the tools or approaches we need to prioritize, develop, and then implement, they can't be done in a top-down way. So in order to get to a menu of options for treatment for TB that would satisfy or start to look like differentiated people-centered care, we need the TB community. We need people who are affected by TB survivors to be leaders in that and certainly participating to help us understand what works for them, right? One of the things that the paper brings out really strongly, and unfortunately, it's not a difficult point to make because it's there in the history, is that DOT was developed in an utterly and completely top-down manner. It was developed in that manner, and then it's been promoted, and it became dominant without the voice or concerns of the community. So in terms of what social scientists can do, I mean, if we're talking about how to actually move away from DOT, how to improve the treatment model, I would say it comes down to embracing differentiated people-centered care and to ensuring that they're partnering with and promoting and working with the communities affected by TB as they do their research and as they think through how to solve this problem.
Okay, so then the last question that I will be asking is, as somebody who is interested in mixing their research with health and law, what is something
Yeah.
that you would want to tell an aspiring student who may be entering the law and health space?
Yeah, that's a good question. So I would say, take every opportunity you can while you're studying. And so if I'm thinking about, law students, right? I've taught at two different law schools and I was a law student myself. I would say to pursue any opportunities available to you to get involved early on. And that could be through courses, seminars in the US, and I think in Canada as well. There are legal clinics at law schools, which provide experiential learning experience or opportunities where students do legal work under the guidance of a professor. And if you have a clinic that's in the health space, do that, take advantage of that. I think considering a master's in public health is a smart thing for whether it's social scientists or lawyers or young lawyers who are interested in the area. Masters in public health, there's a diversity in terms of what they focus on, the kind of skills that you can gain in those programs. So I think that's a smart thing to consider. And I would say though, whether you're at the stage of a student or kind of early on in your career, though, the number one thing that has been important for me has been kind of immersing yourself in some area of health or the health system or the health research that interests you, and learning from doctors, learning from health workers, engaging and learning directly from people affected by the health condition or the concern or the issue that you're working on, because that's the way that you can, along with your education, can really become kind of a multidisciplinary or an interdisciplinary researcher or worker. And so I would just say from my experience, those relationships with doctors, with people living with HIV, people, TB survivors have been the most enlightening for me to kind of figure out my path at the intersection of health and law. It's like you have to embrace the idea that it's multidisciplinary and
Yes.
interdisciplinary. And I think it poses a challenge and can be, maybe uh, something that folks are fearful of, but actually it's very rewarding to the more you kind of go down that path. And I think it's something that if it's attractive to you, you have to embrace it and kind of work to learn about the other field that may be new to you.
So, thank you so much for taking the time to discuss these questions with me. I really appreciate your expertise, and I know that a bunch of other Shift TB contributors who might be watching this video in the future will also be really, really interested and grateful for this interview. I hope that this paper will inspire and inform future practices within the tuberculosis field. So, with that, I will close this interview, and thank you again, Brian. It was a pleasure speaking with you.
Thanks so much, Hannah, and thanks to Shift TB. It's been a lot of fun. Bye bye.
Bye. Bye.